When a healthcare system reaches the breaking point, the instinct is to look for inefficiencies, a logistical bottleneck, or a failure of management. But the crisis in Bangladesh cannot be optimized away through better scheduling. This is the physical reality of the country's public health infrastructure. Patients are lying directly on floor mats because every available bed and the space between them is occupied. The system is buckling under a strict mathematical deficit. The raw human capital required to process the population's medical needs simply does not exist. This diagram represents the deficit: 3.05 doctors and 1.07 doctors per 10,000 citizens, a 90,000 physician shortfall nationwide. Thus, 77.3% of demand spills into the private sector, causing a financial crisis for the 21.8% in poverty paying out of pocket. To prevent total systemic collapse, the government's Smart Bangladesh 2041 framework recognizes that linear capacity building, training enough doctors to fill the void, is mathematically impossible. An entirely different architectural approach is required. Bridging this 90,000 physician gap relies on a three-tiered digital stack: aggressive data interoperability, AI diagnostics as force multipliers, and localized workflow integration. Expanding physical beds or wards addresses the symptoms of the crisis, but it cannot bridge the human capital deficit. Closing that gap requires a digital infrastructure to process care and diagnostic decisions at scale. We can visualize this solution as an interconnected architecture. The foundation is data interoperability. The scale of community health operations in Bangladesh is massive. BRAC's Mobile Health Initiative currently manages 90 million beneficiaries across 64 districts, generating over 540 million distinct data points. But those millions of data points must be collected and accessed on basic, low-memory devices, often far from urban cellular towers. Upgrading this system to global fast healthcare interoperability resources, or FHIR, standards presents a paradox. The massive data payloads required to meet global compliance crash rural 2G networks and overload standard mobile hardware. The engineering solution involved utilizing Google's Open Health Stack and the Android FHIR SDK. By deploying these tools, developers optimize the open-source OpenSRP application specifically for low-bandwidth environments. This optimization created a true offline-first architecture. A single field worker's device can cache up to 19,000 service parameters and 20,000 patient records locally without needing an active network connection. Comparing standard loading times against the optimized Open Health Stack, local caching achieves a 35-fold performance increase in loading family and service data directly on device. Furthermore, UI pagination speed increased 8-fold, eliminating the lag that previously bottlenecked field clinics. Global health data standards are effectively useless in the Global South unless developers re-engineer them to survive the severe constraints of rural digital infrastructure. Once the offline data layer is stable, the architecture can support its second tier, specialized AI diagnostics. Consider the specific clinical bottleneck of diabetic retinopathy. Bangladesh has over 1.3 million diabetic patients requiring annual retinal screening, but a national supply of only 6 to 9 ophthalmologists per million citizens. Google developed the Automated Retinal Disease Assessment System, or ARDA, specifically as an algorithmic bridge to process this unmanageable screening volume. ARDA proved its clinical viability during extreme high-volume deployments at specialized centers like India's Aravind Eye Hospital. ARDA achieved 97.1% sensitivity and 96.5% specificity. Adapted locally for youth and through rural applications like Drishti, hitting 93% accuracy, these AI models flag critical cases for scarce specialists, increasing overall clinic screening throughput by 40%. In resource-starved systems, AI acts as the primary mathematical multiplier to achieve screening coverage for 1.3 million patients. But deploying accurate models is insufficient without the final tier: ethical workflow integration between the AI, the doctor, and the patient. Direct-to-consumer medical AI apps fail here due to hardware realities. Smartphone penetration is only 41%, and severe socioeconomic gender divides restrict device autonomy. The most vulnerable demographics, particularly pregnant women in rural and impoverished families, frequently lack independent control over technology or medical decision-making. Pushing generalized AI models trained in the global north into these environments creates a severe risk of epistemic injustice, where a patient's capacity as a valid source of knowledge is actively undermined by the system. Contrasting structured Western clinical data on the left with fragmented, localized rural symptoms on the right, the system commits testimonial and hermeneutical injustice when the AI structurally undervalues marginalized input or fails to parse regional dialects, resulting in rejected misdiagnoses. To counter these biases, the 2015 Clinical Assist pilot in Comilla utilized an arguable AI framework. Instead of overriding the local physician, the system acts as a specialized assistant that the doctor can accept, modify, or overrule. By integrating seamlessly into the actual field workflow and preserving physician autonomy, Clinical Assist achieved a 94.7% overall diagnostic accuracy and 98% accuracy in chronic care cases. An AI model is clinically useless and ethically dangerous if it forces a rural physician to conform to a Silicon Valley workflow. The software must adapt to the constraints of the clinic, not the other way around. This complete three-tier architecture requires all layers operating in sequence to function. You cannot secure ethical AI workflows at the top without high-throughput diagnostic models in the middle, and neither can exist without an offline-first, interoperable data foundation. Sustaining this digital infrastructure requires specialized capital, which is increasingly flowing through global grant initiatives like Google.org's funding programs. Their AI for Government Innovation Challenge directs up to $3 million toward modernizing public service portals using generative AI models. Accessing this capital requires strict compliance. Local NGOs and engineering teams must verify their operations through platforms like GoodStack and secure clearance from national registry boards. These technological integrations and compliance structures ultimately serve a single purpose: preventing total systemic failure of care for the populations relying on them. The Bangladeshi models shift the focus from lab-based computational benchmarks to operational resilience at the furthest, most disconnected edges of the network.